Good evening. This is Dr. John Bennett, televising from Miami for Neurosurgical TV. We have another in the Conference of Pediatric Neurosurgery. We're affiliating with the IMS Hospital in New Delhi, led by Vivek Gupta of the Neurosurgical Department. We're having a conference on pediatric neurosurgery. And today, we have the honor of having Vivek Tandon, MD. He's going to give us a talk on neuroimaging of pediatric brain tumors.
So, hi, everybody.
Hello.
I will be speaking on pediatric brain tumor imaging and what we should be doing, how we should be diagnosing. The most important aspect for a neurosurgeon is first to understand where the tumor is located, whether it is
presentation.
Pardon?
Go ahead. We have someone joining late here. Okay, you're all set.
So whether it is extra-axial or intra-axial, whether tumor is benign or malignant, and what kind of tumor is that. So when we want to analyze whether a lesion is extra-axial, we look for a CSF cleft, cortical gray between mass and the white matter, and usually the extra-axial lesions, they displace the subarachnoid vessels and space. They are broad, dural based, and they show bony reaction. In comparison to that, when you look at the intra-axial lesions, they usually narrow the CSF space. They displace the cortex towards the periphery, and edema starts from the boundary of the tumor. Like in this case, you can see that, like in this case, where the presentation is. Like in this case, you can see here that it's an extra-axial tumor, probably a meningioma. It is broad, dural based. There is a CSF cleft which is there, and the cortical gray matter which is here, it's slightly pushed and not infiltrated.
Excuse me, Vivek. You're on the slide. I don't know if the slides are advancing. You're on the location slide now.
Is it on the location slide?
Yeah. Now, okay. Now, extra-axial versus intra-axial. Is that the right slide?
Yeah, it's the right slide.
Okay. Okay. I'm sorry to interrupt.
Now, can you see now?
Yeah, I can see extra-axial versus intra-axial.
So when you look at the intra-axial tumor, you see here that though it looks broad-based, but still there is some amount of cortical mantle which is present between the tumor and the dura. Moreover, the tumor looks like infiltrating the cortical matter here. And usually in such patients, when the edema starts, it will start immediately from the boundary of the tumor. While in these cases, when the edema starts, the vasogenic edema usually is slightly away from the site of the tumor. So this is what we are looking at to differentiate between extra and intra-axial tumor. The location of the tumor again is extremely important. In pediatric patients, most of the tumors are located in the infratentorial compartment. Most of the most common tumors are cerebellar astrocytomas in the infratentorial compartment, followed by Medulloblastomas, brainstem gliomas, and Ependymmomas. In the supratentorial region, it is only around 13 to 14% of all pediatric brain tumors are seen. Most common tumor is astrocytoma in that region. 90% of the brain tumors in neonates are neuroectodermal in origin, and teratoma is one of the most common tumors that are seen in the neonates. When we are looking at a picture of an MRI, we can surely distinguish between a benign or a malignant lesion. A tumor invading and destroying the normal brain tissue with lot of edema and tissue necrosis is likely to be a malignant tumor. However, a tumor pressing on the normal tissue and causing increased pressure within brain because of that might be a benign tumor. During the course of this lecture, we will be discussing pilocytic astrocytomas, ependymmomas, medulloblastomas, brainstem gliomas, hypothalamic hamartoma, optic pathway tumors, choroid plexus tumors, craniopharyngiomas, germ cell tumors, sega, gangliogloma, peanuts, Langerhans cells, histiocytosis, epidermoid, and dermoid. Coming to the pilocytic astrocytomas, these are the most common tumors which are seen in the pediatric age group. Around 40 to 50% of primary brain tumors in pediatric age group can be because of the pilocytic astrocytomas. The incidence between male and female is usually same. There is no difference. There is no, and the most common age group is between 5 to 15 years. Features of raised ICP are seen when they are located in the supratentorial compartment and when they are involving the cerebellum, because since they are laterally placed or involving the vermis, a person can have ataxia. These tumors are usually solid and cystic. They have an enhancing mural nodule, and 20% of these patients can have calcification, which can be appreciated in CT or in the GRE images, which appears as a blooming. Though these are low-grade tumors, but surprisingly, when you do an MR spectroscopy in these patients, the appearance is of high-grade tumor with choline peaks. The 25-year rate of survival is very good, and these patients usually survive 90% of the time. And this is a picture of a pilocytic astrocytoma that we operated.
I'm sorry to interrupt you. Vivek, I'm sorry to interrupt. You're not showing the slide. You need to click on the slide on the left column to change it. Yeah, okay, that's it. Pilocystic astrocytoma, okay. You got to click on the left column.
Okay.
Okay.
So how do I do it then? From here?
You click on the left column to change the slide. Each slide, you click on it to change it.
But these slides, they have an animation. So will they work like this?
The animation is not working. The pilocystic astrocytoma?
Yeah, this slide has an animation. So this animation, I believe it's not working.
No, okay,
here.
no.
So how do I do it then?
How do you do the animation?
Yeah.
I really don't know. I don't know. Click on it twice. Have you tried clicking on it twice? Click on it twice. See if that works. No, it's not working. Well, I suppose we'll have to do without the animation for now.
From here, it's not working. But when I'm using it from the main PowerPoint presentation, then I believe it's working here.
Oh, okay. Well, whatever you want to try. You want to try something different?
Can you see right now?
I can see the pilocystic astrocytoma, but no animation is working.
Oh, so
unfortunately.
Anyways, then what I can do is I can present maybe without animations. What
yeah, I guess so. And just to change the slide, click on the column on the left.
But okay. Even the slides are not changing from the Google Hangout site.
No, they're not changing. They're changing. Okay, just let me know when you want to change the slide. I'll tell you if it changes. Okay?
Okay. So this is a case of pilocytic astrocytoma. Usually these tumors are hypo-intense on T1 weighted images, hyper-intense on T2 weighted images. And unfortunately, since that PowerPoint is not working, I can't show you that these tumors enhance brilliantly on contrast. If there is a mural nodule, that part of the mural nodule is going to enhance. And this is what the appearance of these tumors are. These are usually benign tumors, and once excision has been done, you see a good survival rate in these patients. Now, John, I want to change the slide. How do I do it?
Let's see you change it. Click on the slide on the left column.
Yeah, I'm doing that, but it's not working.
Oh, it's not changing? Okay.
No.
Geez, I can't remember. How did we do this in rehearsal?
Yeah, but it was changing then.
Oh, it was? Okay, well, let's go back to figure out what we did. There, it changed.
Okay.
Okay. You got to click on the slide.
Yeah, now coming to the medulloblastomas, these are malignant tumors. 15 to 20% of the pediatric brain tumors, they comprise of pediatric brain tumors. 4 to 11 years is the age group, and maximum number of patients are seen at 5 years of age. The male to female ratio is 2:1. and 1/3 of these patients, they present with drop metastasis. These tumors usually arise from the superior medullary vellum, and when you look at the MRI picture of these patients, you usually can make out the brain stem versus the tumor interface in these patients if it is not invaded. They are, in children, they are usually located in the midline, while in adults, they are usually located on the lateral aspect. They show features of raised ICP at the clinical presentation. Apart from that, patients may have cerebellar symptoms also. The 5-year survival for the disseminated tumors is around 35% if these patients have drop mets or the cerebellum is studded with the metastasis, then it's around 35%. But for non-disseminated patients, survival is good. 60 to 70% of these patients survive. Coming to the MRI picture, on T1 weighted scan, these tumors are hypointense to gray matter. On contrast, they enhance heterogeneously. T2 to FLAIR, they are iso to hyperintense to gray matter. Because of the heterogeneous nature of these tumors, because of the areas of calcification and necrosis, it is usually heterogeneous picture that we see. In DWI imaging, there is restriction. Because these are round cell tumor, the nuclear to cytoplasmic ratio is usually low, and because of that, restriction is seen with low ADC values. MR spectroscopy, as is expected in malignant tumors, shows elevated choline, decreased Na, and may also show a taurine peak at 5. This is a picture of medulloblastoma, which shows on T1 weighted scan, it is iso to hypointense. On T2 weighted scan, the tumor is hyperintense. And on giving contrast, there is brilliant to heterogeneous enhancement which is seen in the axial, sag, and the coronal images. And this is a diffusion weighted scan of this patient, which shows that areas of restriction in the tumor because of the high cellularity and content of these tumors with low ADC values, and this is quite pathognomic of the medulloblastomas. Coming to supratentorial primitive neuroectodermal tumors, like medulloblastomas, these are also round cell tumors. Cranioblastomas are the most common form of these tumors, followed by Ependymoma and Medulloepitheliomas. The mean age of occurrence of these tumors is around 5 years. They can be solid and cystic. The MRI has, interestingly, though these are malignant tumors, but in the MRI picture you can see that the peritumoral edema usually is low. They have heterogeneous contrast enhancement because of the necrosis which is there in these tumors, and some of them also might be harboring solid and cystic areas. The diffusion weighted images, they usually show restriction at times when they are highly malignant and necrosis is there. MR spectroscopy shows elevated choline and decreased Na ratio. Coming to ependymomas, these are around 10% of the primary brain tumors in children are because of ependymomas. 70% of ependymomas are usually infratentorial, and it's more commonly seen in male patients. It has a bimodal peak distribution for the occurrence and the first peak is around 1 to 5 years of age, and the second peak is around 35 years of age. They arise from the fourth ventricle. These are plastic tumors in the sense when the tumor starts growing into the fourth ventricle, it can expand the fourth ventricle, and it also goes out through the foramen of Luschke and Megendie. And that is why you have the typical appearance that you see in these tumors. The patients usually present with raised ICP, and the 5-year survival for these patients is around 60 to 70%. 50% of these patients, they have calcification, and which can be very well appreciated in the CT scan and the gradient images where a blooming is seen. This is a slide of a patient of ependymoma that I operated few days back. You can see the tumor is iso-intense and it has cystic areas in it which are bright on T2 weighted images, and on FLAIR and in DWI images, there is some amount of restriction. The tumor shows contrast enhancement, which is heterogeneous in nature, and here you can see the tumor is going out through the foramen of Luschka towards the outer aspect of the CP angle cisterns. Coming to hypothalamic hamartoma, these are basically heterotopias. They are not tumors in true sense, they are heterotopias. They are isointense to gray matter on T1 weighted images and T2 weighted images. The tumor can be sessile or pedunculated. There is no enhancement on contrast. They can have some amount of fat and they can have some amount of cysts. The usual presentation is which is there is gelastic seizures or precocious puberty, and these are very treatable lesions. You can do gamma knife, you can do laser surgery, you can do disconnection surgery for these patients, and Dr. Chandra had just shown you in the previous lecture how we had operated few of these patients with good outcomes. Coming to opticochiasmatic gliomas, 10 to 15% of supratentorial tumors are associated with 10 to 15% of supratentorial tumors in pediatric age group can be because of opticochiasmatic glioma. These tumors are found in association with neurofibromatosis. The histopathological examination usually shows juvenile pilocytic astrocytoma, which are low-grade tumors, WHO grade 1 tumors. Patients usually present with decreased vision or diencephalic syndrome, where they might be cacaxic, where they might be anorexic also, diabetes insipidus because of the pituitary involvement, or endocrine dysfunction, which can range from hypopituitarism to precocious puberty in these patients. Since these are low-grade tumors, they are pilocytic tumors, they show a similar kind of a picture, which is on T1 weighted scan, you will see a hypointense mass. On T2 weighted scan, you see a hyperintense mass, and on FLAIR, hyperintensity is also seen. On giving contrast, solid part of the tumor usually enhances. A solid part of the tumor usually enhances, and this is what the picture looks like. This is a T1 contrast fat sat image. You can see that there is some amount of enhancement which is there, and this is another patient of opticochiasmatic glioma where a brilliant enhancement is seen, and the tumor is seen involving the optic pathway and follows the optic pathway and can reach even up to the brainstem. This is a T2 weighted scan which shows a tumor in the opticochiasmatic region, and the tumor is bright on T2 weighted and FLAIR images. This is a FLAIR image. Coming to choroid plexus tumor, 70% of these tumors occur before the age of 2 years. There is male preponderance. The lateral ventricle is usually involved, and it is the trigone of the lateral ventricle from where most of these tumors arise. Most are benign tumors. They show features of raised ICP at the time of presentation. It is very difficult to differentiate carcinoma from papilloma without the histopathological examination. It is the histological diagnosis that clinches one diagnosis or the another. The treatment of choice obviously for these patients is surgery, and they have a good 5-year survival. In the MRI or the imaging part, you will see a lobulated mass which is homogeneous. It is a homogeneous mass usually located inside the ventricle, and it has intense enhancement which can be appreciated on a CT scan or on an MRI. Choroid plexus carcinomas, when you compare their imaging to the choroid plexus papilloma, you will see a minor difference in the form of these tumors might be irregular if they are highly malignant, and they also may show vasogenic edema because of the involvement of the surrounding vessels. And this is a picture of a patient of choroid plexus tumor. This is a T1 weighted scan which shows the tumor is involving the whole of the ventricle. Probably it started from the trigone and it has now involved the whole ventricle. The FLAIR weighted image, you can see it as a hyperintensity in the region. They are located inside the ventricle. On SWI imaging, there can be areas of microbleeds which might be there, and on GRE they might also bloom. While on the giving contrast, you can see a lobulated mass which is enhancing on contrast. And this is the scan of another patient which shows a lobulated mass inside the ventricle, and this mass is showing brilliant enhancement. Coming to craniopharyngiomas, craniopharyngiomas are the tumors which are seen in adults as well as in children. In children, the most common variety of craniopharyngioma that we see is adenomatous type, while in adults, it is the papilloma type of craniopharyngioma that is usually seen. These patients usually present with uh, hypopituitarism, diabetes insipidus, and at times, because of the mass effect of the tumor, the patients might have the visual symptoms also. Or due to the involvement of the large tumors like these, a patient can have symptoms pertaining to the frontal lobe, or to the compression of the brainstem can lead to long tract signs or symptoms due to the brainstem compression in these patients. And these can be multi-compartmental tumors. These are solid and cystic tumors, and they can have areas of calcification within them. This is just one of the tumors that we operated few days back. It's showing that on a T1 weighted image there is a hyper intense cystic area which is seen inside the brain, which is involving multiple compartments, the supratentorial compartment and the infratentorial compartment. This hyperintensity in this kind of a cystic mass is because of the fluid that these tumors contain, which is a machine oil-like fluid which is there, and because of the particulate matter in it, there is hyperintensity that can be seen. And this is just one example, few examples of craniopharyngiomas. This is a patient where you can see on a CT scan that there are few areas of calcification which are well evident, and there is an area of cystic cavity which is also present. Such appearance is very characteristic in this region for craniopharyngiomas. This is a T2 weighted scan showing a tumor in the suprasellar region with hyperintensity that shows fluid, and with some areas which have solid component also. And on contrast-based images, the solid part of the tumor shows heterogeneous contrast enhancement in most of the cases. Coming to brainstem glioma, 15% of primary brain tumors can be brainstem gliomas. 80% of these tumors, which are brainstem gliomas, are half high grade in nature when they occur in children. There is no male to female preponderance. The age group usually that is involved is 3 to 10 years. Pons is the most common site. These tumors are classified into 4 types. It can be diffuse, involving the whole of pons, expanding the pons, focal, arising from a particular site in the brainstem, and exophytic when it is growing outside rather than inside. Cervicomedullary when it is located in the cervicomedullary region. The best prognosis is when the tumor is exophytic and focal, and the worst when it is diffuse, because excision of diffuse type of a pontine glioma is extremely difficult and may not be feasible. The differential diagnosis is because of the encephalitis. The differentiating point is the expansion of the brainstem in these tumors. These are usually non-aggressive tumors if they occur in association with neurofibromatosis. The usual presenting symptoms of these patients are involvement of the cranial nerve and seventh nerve palsies, which are involving the both sides, and also presence of long tract signs or other cranial nerve deficits depending upon the site of the tumor and the extent of its growth. This is an example of a brainstem glioma that we operated in the last week. You can see there is a tumor involving the brainstem. It has a cystic part, and it also has a solid part which is there. Usually these tumors are solid in nature, unlike this example, They are usually solid in nature, expanding whole of the brainstem, and enhancing on contrast at times. When an MRS is done and the voxels are placed in this region, usually a choline peak is seen with decreased NAA peak, and the ratio of it is rise, and taurine is also increased. Coming to germ cell tumors. Germ cell tumors, they are very common in the pediatric age group. Most of the patients with germ cell tumor, uh, they have a midline tumor, which is there. They have a midline tumor, and the most common varieties of germ cell tumors are germinomas, teratomas, and the teratomas. These are usually midline tumors which are located in the pineal region. There is male preponderance, and except benign teratoma, all are considered as malignant. Germinomas, they do have a better prognosis. Tumor markers like beta-HCG, AFP, and LDH, they might be elevated. But in patients of, say, germinoma, at times, all the markers, they are in the normal range. Most of the tumors are not radiosensitive, but some, like germinomas, are extremely radiosensitive tumors, and prognosis in such patients is very good. This is an example of a patient with germinoma. You can see a brilliantly enhancing mass in the region of the pineal gland. And these patients are usually male, and young males, it's a common diagnosis. These tumors can have droplets, and they can involve the pituitary region also. That clinches the diagnosis most of the time. Since these are highly cellular tumors, therefore on T2 weighted images they might appear hypointense, and on DWI weighted images these tumors can show restricted areas of diffusion. I'm not sure uh, why the animation is not working, but this is one example of the previous tumor where we have shown that the MR perfusion shows increased perfusion in the region of the tumor. That is also one of the hallmark of the germ cell tumor. Another form of tumor is teratoma. It is in 2 to 5% of primary brain tumors are teratomas. They are again more commonly seen in males, but mostly teratomas are benign tumors, exception being the malignant ones, but most of them are benign tumors. Most of the patients, they present with hydrocephalus as they are located in the midline region, and because of the compression of the aqueduct, usually these patients develop hydrocephalus. In the pineal region, when they are seen, they usually have some degree of calcification, and there is fat also. The fat appears like a clump in these patients. Soft tissue may show enhancement, and malignant ones may show edema and irregularity. This is an example of a patient where the teratoma is seen. It's a large tumor, solid cystic tumor on T1 weighted images, and it has probably a malignant type of tumor also, because you can see there is a area of hyperintensity which shows maybe bleed has happened, and it's a fluid level which is seen in the ventricles also. But most of these patients will have areas which are bright on T1. These are lipomatous areas, and areas which show some degree of enhancement, and these are the areas which are of soft tissue. And on CT, you can look at the calcifications which might also be seen in this region. Subependymal giant cell tumors. They are associated with tuberous sclerosis. They occur near the foramen of Monro, and patients with tuberous sclerosis who have this kind of a lesion appearing on the contrast scan, which are brilliantly enhancing on contrast, they are usually subependymal giant cell tumors. Hydrocephalus is a common feature in these patients because of the periventricular location. These are low-grade WHO grade 1 kind of tumors usually. Gangliogliomas, These are the tumors that are usually seen in the temporal lobe. They have a very common occurrence pattern in the children, and they have a very common occurrence patterns in the children. Usually, males are more when compared to females. Most of these patients present at the age of 3 to 6 months with the epilepsy, and they are usually cortical based. They have a nodule which enhances on contrast. They can also present with hydrocephalus, but 75% of these patients, they usually survive beyond 5 years after a good surgery. This is just one example which shows that there is a lesion, solid cystic lesion probably, which is present in the temporal region on the right side, and on GRE it shows blooming which is there. It is because of the calcification which is present in the lesion. In the post contrast, you can see there is enhancement in the contrast in this case. Coming to DNUTs, these are benign tumors. 20% of these patients, they present with refractory seizures. Most of these cases have lesions in the temporal lobe. These can be solid or cystic. They are associated very commonly with cortical dysplasias and gangliogliomas. This triple pathology is rare, but many times it is seen. They are slow to grow, or they may not grow at all. The cortical based lesions can also be multicystic. Some of them, they have calcification, but 40% of these cases, they show a minor degree of enhancement. And the characteristic feature is bright rim that you see on the flare, which can be appreciated here also. Their typical appearance is wedge-shaped. Complete excision of these tumors leads to a good survival and prognosis. The Langerhans histiocytosis is actually a disorder of the reticuloendothelial system. These tumors can rarely involve the skull also, and in calvaria when they present, you can see here, if I move this image maybe here, then maybe you can appreciate more because the animation is not working. They present like punched holes. These lesions on CT scan show erosion in the calvaria, and the edges of the bone are usually beveled. On MRI, these lesions can present with hyperintensity, which can be appreciated on contrast. They brilliantly enhance on contrast. And in CT also, they are hyperintense, hyperdense, and on giving contrast, these lesions enhance. They have a good prognosis and usually are amenable to surgery when they are located on the surface of the scalp. And coming to the towards the end of the slides that I have, epidermoid and dermoids are also extremely common tumors that we come across. Epidermoids are more common when we compare them with dermoids. They contain keratin, cholesterol, and cell debris. While the dermoids, they have same kind of a keratin that you see in epidermoid. Apart from that, they also have hairs and sebum. The lining of epidermoid is stratified squamous epithelium, while in dermoid, there are also some dermal appendages which are present. The location of epidermoid can be midline, but more often than not, we see them in the lateral aspect. While the dermoids, they are mostly located in the midline. Epidermoids are usually isolated lesions that one can find in the brain, but dermoids can be associated with other anomalies involving the whole of body in 50% of the cases. The meningitis that occurs in epidermoid is usually aseptic in nature, while in dermoid, the meningitis that happens is bacterial in nature, and because it is due to the dermoid having a communication from the outside. This is a picture of a patient with dermoid that we operated few months back, and you can see the dermoid is located in the midline. It has a hypointense area with a hyperintense area which is there, and the hyperintensity can be in T1 weighted images due to the fat which might be present in these lesions, or these are more heterogeneous in comparison to the epidermoids that we see. This is an example of an epidermoid case which we have operated, which was there, and this patient has hypointensity in the CP angle lesion, and which is brighter or hyper intense on T2 weighted images, and characteristically they can be differentiated from arachnoid cyst by the restriction that is seen in TWI images. Thank you.
Very, very good.
Very good.
Thank you, Vivek.
Thank you, Vivek.
Well, what a teaching presentation. And don't worry, lots of students will see it on video. Do you have any comments or questions, Deepak? I don't know if you're there. Your icon's there.
John, I couldn't understand why the animations were not working. So
no, unfortunately.
Slides and a lot of animation that was there in the slides.
Well, we can always repeat it at a time of your convenience if you want, and we'll try to figure it out. I'll be glad to repeat it, and then we can just insert it with the rest of the presentation.
Okay.
Not now, but sometime this week if you want. I'll be glad to repeat it, and we'll fix your camera too.
Okay.
Okay, does that sound good?
Yeah.
Okay, super. Thank you very much. And just let me